Hello and welcome again to Conceptual Surgery, and the topic that we are going to discuss today is on mesentery and omentum. I am Dr. Anubhav Vindal from Maulana Azad Medical College, and I welcome you all to Conceptual Surgery. Now, first a bit on the omentum. So as we all know, omentum is called the abdominal policeman, and there are two, in fact, anatomically if you talk, there are two omentums which are present in the peritoneal cavity. One is the greater omentum and one is the lesser omentum. The greater omentum is the one which hangs from the greater curvature of the stomach, and the lesser omentum is also sometimes known as the gastrohepatic ligament, which runs between the undersurface of the liver and the lesser curvature of the stomach. So why is it called the abdominal policeman? Because it is one of the very important properties of omentum to limit intraperitoneal infective processes. So the omentum is like an apron which hangs from the greater curvature of the stomach down over the colon and over the small bowel, and the lower part of the omentum almost reaches till the pelvic brim. So therefore it reaches almost all parts of the peritoneal cavity, and whenever there is any infection or inflammation anywhere in the peritoneal cavity, it has the capacity to migrate over there and form adhesions in order to localize that inflammatory process, so that the inflammatory process becomes localized and does not become a generalized process. But in order to affect this property, in order to be able to migrate to that area, the omentum also in this process causes adhesions, and these adhesions can be therefore a cause of obstruction by forming bands around which the intestine can twist, and intestine can get kinked, and intestine can get obstructed. Omentum is also involved in tuberculous affliction of the peritoneal cavity in form of tubercular peritonitis, and also in carcinomatosis of the peritoneum. Omentum contains a large amount of lymphatic tissue, and therefore any affliction which affects the lymphatic system of the peritoneal cavity also affects the omentum. One of the very frequent way in which you can kind of find out the very common presentation in which omental thickening is palpated is an epigastric lump, and an important differential of this epigastric lump would be a mass arising from the stomach. Now, when we talk about the diseases of omentum, the only thing that I will discuss today is torsion of omentum, which in itself is a very rare emergency. So because the omentum is attached by only one point, that is, although it is a broad point. So if you look at the stomach, this is the stomach, this is the lesser curvature of the stomach and the greater curvature of the stomach, and the omentum hangs like an apron from the greater curvature of the stomach like this. So a part of the omentum which attaches to the diaphragm is called the gastrophrenic ligament, which comes in relation with the spleen and has the short gastrix running, is called the gastrosplenic omentum, and the one which is free is the greater omentum. Now, because of its broad attachment, it is rare for the omentum to twist. But in rare occasions, when especially if there are abnormal adhesions of the omentum to intra-abdominal organs, the omentum may twist and may present as intra-abdominal emergency. Now, this is a rare emergency, and therefore it is seldom diagnosed correctly, because you would not keep omental torsion as a differential of the common abdominal presentations in emergency. And the most common differential for which it is mistaken is acute appendicitis. So like I said, it could be either a primary torsion or it could be secondary to an adhesion of old focus of infection to which the omentum has gone and has limited, and in the way has formed an adhesion. How does the patient present? The patient is most frequently a middle-aged obese man, and in obese people you know that it is even more difficult to diagnose an acute abdomen correctly. A tender abdominal lump may be present, which is nothing but the torted omentum. And this torsion, what it causes is, because of the twist of the vessels, the vessels get kinked, and because of the thinner wall of the veins are the first ones to get kinked, and later on with the increasing edema and the torsion not getting detorted on its own, a time will come when ultimately the arteries will also get torted and there will be an interference of the blood supply of the omentum. Now, once the omentum's blood supply gets affected, it will ultimately cause gangrene of the omentum, which may give rise to bacterial peritonitis. Now, whenever a patient with abdominal emergency presents, and suppose you have diagnosed the patient as acute appendicitis, you open up the abdomen by a gridiron incision in the right iliac fossa, and when you see the omentum, the appendix is absolutely normal. So it is a dictum that you explore the terminal ileum in order to rule out a Meckel's diverticulum. Now, if you explore the terminal ileum and the Meckel's diverticulum is also not there, but still there is purulent fluid inside the abdominal cavity, so one, you have to do appendicectomy because you have made the incision, so you don't want the appendix to be lying there in presence of that incision and that scar. Second, you must convert it into a midline laparotomy to do an exploration of the peritoneal cavity, so that the abdominal pathology which has actually given rise to that presentation does not get missed out. Now, once you open up the abdomen, you would find that the omentum is actually the culprit, and you would find that the omentum is either having impending gangrene or is frankly gangrenous. So, the treatment for a gangrenous omentum is a surgical excision. You have to excise the omentum. It's very simple. You just keep on taking ligatures at the base of the omentum and excise all the devitalized omentum. Next, we come on to the disorders which affect the mesentery. So, the first one is mesenteric injury, and we all know that mesentery is a very common organ which is affected in blunt trauma of the abdomen, and it can also be affected in penetrating trauma. So, both the blunt trauma as well as penetrating trauma can be the causative factors for causing mesenteric injury. It is a very important cause of hemoperitoneum besides the injury of solid organs like liver and spleen. The management in case of a mesenteric injury is very simple. You find the site where the bleeding is occurring, you give manual compression, put pack, wait for the hemostasis to occur, and then find out which are the vessels which are responsible for hemorrhage. You control those vessels. In case the overlying bowel is gangrenous or ischemic, that bowel needs resection and end-to-end anastomosis. Another fallout of mesenteric injury may be delayed mesenteric ischemia. Now, what can happen especially in blunt trauma is that the mesenteric vessels do not actually get avulsed, and so there is no obvious bleeding. But what can happen is, because of the blunt trauma, there can be intravascular thrombus formation. So, when there is intravascular thrombus formation, the blood supply to the overlying intestine can get affected. Although because of the extensive collateral formation within the mesenteric vessels, this is seldom of consequence. But in case there is a large number of vessels which are affected by this intravascular thrombus, it can cause mesenteric ischemia. Then there is something which is known as acute nonspecific mesenteric adenitis. Now, the name of this disease is acute nonspecific mesenteric adenitis to distinguish it from what is specific mesenteric adenitis, which is specifically related to tuberculosis of the mesentery. In the West, this non-specific mesenteric adenitis is more common compared to the tuberculous variety, whereas in India it is the other way. We hardly see non-specific mesenteric adenitis. Most of the mesenteric adenitis is due to tuberculosis. The etiology is unknown, and some hypotheses say that it may be associated with infection of the ileum with Yersinia enterocolytica. Others say that it may be of a viral etiology, but there is no conclusive evidence to incriminate one specific etiological agent for this clinical condition. Usually it has been seen that 1 out of 4 patients would have a preceding respiratory tract infection, and usually it is self-limiting, but and it is non-fatal, but the